Hello everyone, welcome. This is the case of primary infertility, and the reason behind this, these are multiple fibroids embedded all over the uterus, and we are doing the laparoscopic myomectomy for this case. So our first step is bilateral uterine artery ligation, as we don't use vasopression. So first step is catch hold the IP ligament and give traction to the medial. And the first structure after retroperitoneal dissection is ureter. We have to identify the ureter first. This is the external iliac vessels, and medially this is the ureter. In less than 2 seconds, the ureter is well identified. Then we'll go further, and the next structure will be uterine artery at origin. This is the internal iliac artery is going further, and blunt dissection is good, and the first tortuous structure, bluish in color, will be the uterine artery. So we will hold this artery and dissect it for at least 2 centimeters of its part. Then we will coagulate it. Now this is well visualized. Good length of this we have achieved. Slight more dissection is needed to make the ureter distant and in vision. Now we will just coagulate it, and the ureter is in our vision. Okay, the ureter is going well, and we will coagulate it. We will just coagulate it, and no need to cut it. This is gone. Now this process will be repeated on the another side. So for that, first we hold the IP ligament and give traction medially, and open the retroperitoneum lateral to IP ligament. Now the first structure we have to identify is the ureter. Slow dissection is made here, and further go back, पिछले hold this intestine back, and few cuts are made on back so that the ureter can be easily identified at this level. And we have identified the ureter just below my instrument. Little oozing, we should tackle it immediately, otherwise it spoil our field. We have entered the blunt traction, is good. This is slight oozing, we have to tackle it. So gentle dissection is the need, and I will hold the ureter below my instrument and then dissect the uterine artery furthermore. This is the continuation of internal iliac artery going on, and this is the branch which is tortuous and going medial. This is the only branch. Ureter is in my vision, distant from the uterine artery, and then coagulation. No need to cut it. Gentle. Okay. Now all these myomas we have to remove out. So first this submucous, so subserosal large myoma. So we will remove it out, and the blood loss is purely venous. which is filled in the myomas, and by this method we will avoid the blood loss during the surgery from the systemic side. And catheter कर दो. I am using the shearer with both coagulation and cutting at the same time. First myoma is out. Now we will give incision like every myoma can come out from the same incision. So we will give anteriorly first. And the bladder is filled. So we have to dissect slight amount of bladder and so that we can easily inoculate these lower myomas without damaging the bladder. Okay, this is fine. This is the myoma, this is the myoma, and we will give the midline incision. And we'll try to remove all the myomas from this incision. This is the larger myoma again, and the technique traction and counter traction, and the traction we will give it by the myoma spiral. First, we have reached the plane. Myoma screw is a better instrument, and the traction will be provided, and it will enucleated very well. थोड़ा पीछे छोड़. These few fibers are remaining, and the whole myoma is coming out. The most important prerequisite is to be remain in the proper plane, and proper traction and counter traction is the key for the myoma enucleation. Now, the traction is being applied to another site for this myoma. And these myometrial fibers are being removed away. The myoma number 2 is out. Now, this is another myoma here. I think there is no myoma. This is the deeper myomas. Hold it. These are two deeper myomas. Hold it. Yeah. This is another myoma which is embedded inside. So, frenaculum. Frenaculum. Foot grasper. This side are more myomas. So I have to sacrifice this little of the serosa. this part of serosa is being sacrificed. All that myoma. This is again a subserosal myoma. Okay. This is myoma number 3 is out. This is a smaller myoma. Tenaculum. This is adenomyotic, I think, more than adenomyotic and than the pure myoma. This is adenomyotic. Okay, no problem. So this is the remnant of this tissue, and we have to completely remove it out. This is specimen number 4. Myoma use करो. The tissue is little adenomyotic. The tissue is breaking, not getting hold. First, this is the traction and counter traction. This is myoma number 5. Now, let's see further if there is any myoma. This is another myoma, and we will try to remove it from this same incision. We have to apply the same application principle for the all myomas, and the principle remains the same. Traction and counter traction and proper plane. टेनाकुलम जाएगा, टेनाकुलम से आएगा, छोटा है. Hold with the tenaculum and give traction. Give traction. Enucleate in the proper plane, and this multilobulated small myoma is out. It is multilobulated. This is another myoma, I think. Hold that. This is a larger myoma. Wow, great. Shearer is very important. I am doing sharp dissection as well as the blunt dissection Also by opening the jaw, just hook and open. Just hook and open. Just hook and open. And these fibers we have to cut. Now there is no more myoma in the depth. So no. Is another myoma or not? No, this will be cavity. Specimen number 6, 7, 6. Yeah. Okay. Now palpate and this no myoma. Try palpate. I think we should find another myoma here. If there is any myoma, no. Palpate, no. No myoma on this side, no. Furthermore, deep down here, no. Okay. Now we will suture it first, then we will go down. For the posterior wall myomas, this is another myoma. No, not this. These are the separate myomas between. So hold it. Slide ladder dissection is needed for the proper and efficient suturing. Hold this tissue. Bladder is fine, very low down, and we can suture it very well. Now, statafix, we will suture it with number 1 statafix. Now putting the suture inside. The suture is inside. And we will take deep sutures in single layer. This is 45 centimeter large suture. Knot is broken. Okay. No, there is no myoma. This adenomyotic tissue actually. We can suture it again here. To cover up this serosa, I have taken the suture back. Take it like this. The big suture has this problem. Leave it. No problem. And we will tighten it well. Pull the suture back. This is very deep and dead space here. So we will take it deep. Pull it. Good. Now I will get more. And in this case, Dr. Lokesh Ola is assisting me. Dr. Tanuj is our anesthetist. And our staff, Monica, Madhu, Pradeep, Sunil. And our live is handled by Mr. Rajiv, our wholesale manager and technical person. And this is the defect very, and we have to take it very deep suture here. This is slightly cut through because of adenomatic nature of this tissue. So we have to be careful taking deep bites. Taking deep bites on this side also. I want to introduce you a beautiful girl, Dr. Vrinda from Ahmedabad, our great fellow, is on trolley and observing each and everything very keenly. This is a deep bite, and I'm taking one by one on both sides for proper depth to obliterate the dead space completely. And because this side the fibers were very deep. Okay. Suture is stuck. Okay, leave it once. Little, leave it. This tissue should go inside so that the lesser amount of the raw surface should be present. Half of the myomas we have removed out, and remaining same amount or same number are remaining on the posterior side as well. and my needle is going very deep. So I'm taking one by one. This side, the deeper part, bladder should be away. So less amount of the uterus is remaining, and her AMH is very low. So she is candidate for IVF at this age of 40. Pull this. Okay. I'm trying to obliterate the dead space completely. This one more stitch is needed here. Pull your side. Pull your side like this. And this is the last bite. Now let's examine. Is there any bladder or no? Everything is fine. Half of the job is done. So scissor. वृंदा मैडम scissor देना. Once more examine. Once more, please. Look us once more. Is there any? This is the cervix and this side the major. Okay. Now we will remove out the suture and we will proceed for the posterior wall myomas. Get some suction, please. Maya bar. There is no more blood loss because of bilateral uterine artery ligation. Let's examine planning for the incision and not this side is no. Mostly fibroids are slightly left side, so our incision will be on slightly left on the posterior one. The same vertical incision is being made. Sufficient length of the incision should be made for easy enucleation of the myomas. One more layer deeper the myoma is, and myoma is slightly degenerated, this one, and it will come out by the same principle of traction and counter traction. You can see the use of blunt dissection by the shearer itself. Oh, this one was good. This is the trick for blunt dissection. Just dig inside and open, dig inside and open, and then cut the remnants of the fibers. This is number 7, and This is number 8. Now we have to examine it if there is any myoma. Wow, this little one is there. This one, दूर दूर तक तो कोई फाइब्रोइड छुपा होता है, डर के मारे बाहर आ जाता है कि लोकेश आ गया. और लोकेश इज लाइक दैट एमआरआई मशीन. वेयर इज this one? Okay, hold it. We'll give some incision here. Endometrial cavity or myoma. Locus is telling this is the myoma. No, no, this is the cavity. I think. Cavity. Once hold it. I want to put an incision. Okay. Locus is telling this is a small myoma, and we have to remove it out. Our MRI machine. How can it be like? Good. Actually, I have not reached to the proper plane for this myoma, so this is not coming out. So I have to dissect it well, by blunt as well as a sharp dissection. And oh, this is very deep here. Hmm. One sec. Right. I think one another or not. But no, this is the cavity. Oh, this is the cavity, I think. Let's see. This is the cavity. This is the cavity. Oh. So we have not opened the cavity. This is the is there. Which side? Okay, leave it once. This is the cavity, not a fibroid. Okay, this is the cavity. Okay, leave it. I'm sure this is a cavity, not a fibroid. Now increase the incision. Now you can see the benefit of doing bilateral uterine artery ligation. No more blood loss. Okay, hold this tissue. First remove this. Hold it. Which number? 11 myomas are out. This is a smaller myoma. We will remove it out. Okay, hold it. This one, 12 myomas. And one more myoma on this side. Big and one layer is remaining. Pushing it back by the blunt traction and the myoma will out. The tubes, I think, have gone. Mute. which 13 myomas are out, and what is left in the uterus is any more myoma. Okay, search for any myoma. Is there? This is a smaller, no problem. There is the cervix behind. This is the cervix. Okay. Is there any myoma at this site? No. This is the cavity. This is the cavity bulge. Boggy feeling. And take the grasper and feel that. I think there should be no myoma. No, this is adenomyotic tissue at the fundus. Okay, 9, 9, all clear? Tanush sir, all clear? Do you think any more slight larger myoma is remaining? I think millimetric size of the myomas are remaining inside, but they will autolyze because we have done the bilateral uterine artery ligation. Okay, this is the little बेचारा छोटा सा यूट्रस बचा है अब. Our anesthetist is telling that we can do all these laparoscopic surgeries in the spinal anesthesia also, and we usually do together where the resources are less in a smaller centers. But here we are using general anesthesia only at our center for all the laparoscopic surgeries. सूचर बाहर निकाला पॉट में है मेरा सूचर. Good. And I will try to use my middle port for this suturing. I am not expert in this port suturing, so I will face some difficulty, but let's try. This is the first bite at the angle. This middle port suturing I have learned from our beloved Dr. Jay Mehta, and it's very helpful for the posterior wall suturing. No, you should to take it this like this. This is also a larger number of the suture. There's any knot? No. This is little tricky, the middle port suturing, but very useful. So we should learn it. We should use it wherever we need to suture posterior wall. I am trying to put this knot at the angle of the incision. Looking little difficult, I think. Okay. Good. Thank you, Lokesh. Full thickness bite. Full thickness bite on this side. It's came little near to the previous suture. So I'm trying to took it out from another place. No, the needle is slightly moved. No, I'm not getting it. Okay. So I will take it one by one. I am facing some difficulty by holding the needle holder with the tips of the fingers only. Not as tight. Hold the uterus above, not the suture. Thickness wide. Trying to remove it out on this side. Good. I am slightly succeeded in this step. Remove. Out. Hold like this. Hold the uterus like this from above. Now trying to take suture one by one because simultaneously it is much difficult. I am trying to preserve the fallopian tube. Remove this suture out. It will take some knot, I think. Okay. One. Tighten it. Tighten it. Good. Almost not a good suturing in the posterior wall, but it's okay. And this tube is gone. Sorry, tube. can we do? देखो, oh, tube गई है. This tube is gone because the fibroid was very deep on this side, anterior as well as the posterior on this left side. Okay. Now morcellator ready. Thank you, Sunil. No, sir, everything is fine.
Yes.
I'm not talking about the anesthesia part. I'm talking about the surgical part. Please guide. Any input you want to give? We are not worried about the anesthesia part because you are here, the excellent person. We are worried about the surgical part only. Any problem, Tanu sir, from your part? No, everything is fine. Our part is not fine, I think. I'm not satisfied with the suturing, but what can we do? Okay, क्या करना चाहिए? Second layer. Okay, necessary suture expose हो जाएगा ज़्यादा. One more suture we have to take at this level. Okay, this suture line is loosened by the removing of the fibroids again. So we will take 1 or 2 bite the anterior side. This suture line is slightly loosened and some serosa is exposed. So we are taking 1 or 2 extra bites. We can take 1 more bite here and then scissor. I think it's fine. No, no, don't lock it. 1 or more round I want to take. This suture slightly interiorly. Now, good. What's okay, sir? Yes, sir. Yes, sir. There are so many fibroids and बेचारा छोटा सा प्यारा सा यूट्रस बचा हुआ है. Fallopian tube is damaged the left side. But what can we do? I think we should take one more stitch here or not. Although the hemostasis is good. No needed. Everyone is feeling no need. It's okay. No. Flexion, please. And morcellation ready. Now this is the final picture. Now we will proceed for the morcellation of these fibroids. That will take longer time. So we don't want to keep continue on live. And this is the home. And you can see. Okay. Anteriorly show the final picture. Fine. Now bleeding, everything is okay. Right. Thank you very much. Bye bye.